So I'm going to be chatting to you a little bit about non-healing corneal ulcers, which sometimes can feel like a bit of an eternal battle between the forces of good and evil. I do think that often the forces of good prevail, but we'll look at some of those in more detail. So when we think about non-healing ulcers, the expected healing time for a healthy canine or feline cornea, usually we expect to see that heal in less than a week. And so if we have a situation where the cornea is not healing in what we consider to be a reasonable period of time, we consider that we're dealing with a chronic ulcer. And those, for me, fall into one of two categories. So we can have our spontaneous chronic corneal epithelial defects, or our SCEDs, and then we can have ulcers that are secondary to another primary ocular pathology. So with regards to our SCEDs, they are by definition spontaneous, and so that means that we don't have a known cause for why that ulcer occurs. It is by definition a failure of normal wound healing. And so what we typically have, and I promise this is the only histo image that I'll show you tonight, but on this image you can appreciate that we have this, do I have to come? I'm going to go the dangerous way, so the arrow here that you can see is pointing to this confused, dismature corneal epithelium, and then the arrowheads are indicating this acellular hyaline-like membrane, which is that kind of pinky tissue. And the suspicion there is that the epithelial cells cannot adhere to the underlying stroma because they're being blocked by this tissue. And so that's really the characteristic kind of appearance of that SCED that we see. Looking at our secondary chronic corneal ulcers, so these are a symptom of another primary ocular pathology, and that can be anything from an eyelid issue, disturbance of the tear film, so qualitative or quantitative KCS, various degenerative corneal diseases, and certainly other causes. And so in this situation, very critical that we identify if there is a primary ocular pathology, because of course, even if our diamond burr debridement or debridement of that chronic ulcer is part of our treatment plan, we're unlikely to be successful if we don't treat the primary problem. And of course, that can lead to frustration on your part, on the part of the client or the carer, and certainly leads to increasing patient morbidity. So here I have some examples of those primary ocular problems. So you can see the top image there is an example of endothelial decompensation. We have a fluorescein positive superficial ulcer laterally there, but then we also have this sort of frosted glass appearance to the cornea with a normal intraocular pressure. And so in this situation, certainly we may debride that superficial ulcer, but if we don't treat the underlying decompensation, we're likely to have recurrence or have a failure of success with that treatment. In the lower image here, we have an eye displaying calcific corneal degeneration. So you see here these sort of spider web-like corneal deposits, again, a fluorescein positive erosion. And so we may debride that, but again, that calcific corneal degeneration has to be addressed as well. Let's see what happens. Okay. Eyelid masses, this of course, relatively obvious eyelid mass, but sometimes they can be more subtle. And again, if they have constant contact on that cornea, they can cause that ulcerative keratitis as well. Here we have a feline eye displaying pretty significant trichiasis and entropion, and that fluorescein positive area as well. So again, if we don't address the entropion, we're very unlikely to be successful. Dystechia or ectopic cilia, again, also causing chronic irritation, and so those need to be addressed. And then foreign bodies, so this poor dog in the lower right had this fornical plant foreign body present for a couple of weeks, and so not surprisingly that didn't resolve despite debridement. So our diagnostic approach, regardless, is always to evaluate the history. So do we truly have a chronic non-healing ulcer? What is the signalment of the patient presenting to us? We have some breeds that are predisposed to SCEDs and other ocular pathologies. Of course, a complete ophthalmic exam, so evaluating the eyelids, their position before and after local anesthesia, if that's relevant, based on your adnexal examination. Reflexes, so do we have significant leg ophthalmos or failure of the palpebral fissure to close completely? Of course, your Schirmer tear test, intraocular pressure, evaluation of the third eyelid, particularly the posterior surface and the fornix there. And then, of course, your fluorescein stain and a slit lamp, if you have, is ideal. Some adjunctive tests, corneal cytology and culture, never wrong. And so if you're uncertain, absolutely take those samples because you may rely on them later. And then blood work. I've put a question mark here because there are certain patients, so particularly some of our older patients or those where you're thinking there might be a systemic disease, there are certain endocrinopathies, certain systemic diseases that can predispose a patient to have a chronic ulcerative keratitis that is non-healing despite your best efforts. So a question that we often ask ourselves is, when do we debride? And so for me, if I have a lesion that is fluorescein positive, certainly documented, it has not been healing, it is superficial, we have that hypertrophic epithelium, so those kind of waves, those folds of epithelium around the edges of a fluorescein positive lesion. There is no infiltrate present, so it looks like a very clean corneal wound. We have a stable corneal stroma. And the anterior chamber is underwhelmed with what's happening with the cornea. So if we have no evidence of a uveitis, no hypopia, no hyphema, those are cases that absolutely I would consider debriding. And so here are two examples where we see that fluorescein positive lesion with that characteristic kind of halo effect where the fluorescein runs under the edges of that hypertrophic epithelium would be good choices to debride. When not to debride. So here's some dramatic examples, certainly, but in general, if you have epithelium that does not appear to be hypertrophic, so when that epithelium starts to heal, it can be a little bit fragile. It does not look elevated. It doesn't occur in folds. That doesn't need to be touched or disturbed. It just needs some time potentially. And that goes hand in hand with documented healing. So if you're having a progression of that epithelium, giving it some time to see what it will do, absolutely. Certainly any deep lesion, I would not apply a power tool to. If we have an infiltrate or an unstable stroma, so whether that be malastic, bullous, or sequestrum formation in our feline patients, those are not eyes that I would be comfortable to debride. Or if the anterior chamber is telling us that there might be a deeper issue, so we're having evidence of uveitis or fibrin, hypopia formation, those are examples where I would not want to apply an alga brush. So a little bit of audience participation. Would you debride this cornea? Good. I can see a lot of people shaking their heads. Excellent. So this one here in the first one that I showed you, example of an eye that has a thick kind of creamy infiltrate, a very unstable looking stroma, a deep ulcer. We certainly don't want to be poking around in that with the alga brush. Here, the next image, again, any takers for debridement for this eye? Maybe. So this is a bit of a tricky one. We have a small lesion. It's a bit difficult to appreciate on the picture, but there's almost a bit of a bullous quality, a bit of a gelatinous quality to that small fluorescein positive lesion. But if you look at the anterior chamber, you can see that the pupil is quite myotic. The iris in this patient was quite swollen, and in this lighting it's very difficult to tell, but you can see that the radial vessels in the iris, they are a bit agitated, and so we've got some early rubeosis irides, and this was actually a microperforation and a stromal ulcer. So again, the anterior chamber telling us that something's not right. Here, this one, again, a little bit tricky, but if you look at it closely, you can see that the edges are just not so stable looking. They have a bit of a gelatinous quality, and it's a deeper ulcer. It is no longer superficial, and so again, not one that I would want to apply the alga brush to. So keratomalacia and a stromal ulcer. This eye, what about this eye? No, great. So this is a sequestrum formation in a feline patient. We're not going to be applying the alga brush to that. And obviously you can see that there's a bit of a theme happening on this slide. Oh, there we go. Here, this one again, a little bit trickier. So we have an eye that is actually post initial diamond burr debridement. And so we see that there's this exuberant granulation tissue with some corneal microbullae, some pigment and some fibrosis forming. We don't need to debride this. We've already had documented healing, and it needs some time and some supportive care, and so more so topical therapy than a debridement here. So this is an example of a complex healing process in the cornea. This patient with an erosion, but also a stromal ulcer, and you can see in the erosion there is no halo effect. So that's actually quite stable epithelium, but that ulcer may cause us some problems. And then lastly, I think this is quite clear. We've got dysmetacel in this patient, and so we don't need to, poke around in there either. And so when in doubt, absolutely you can consider beginning topical therapy and rechecking that patient in 3 to 5 days. At that initial consultation, consider doing a cytology and a culture, because ultimately, if you begin topical therapy and it goes in that positive direction that you're hoping for, you still have that information should you require it later. If, on the other hand, they come back in 3 to 5 days and things look worse, you're not behind the 8 ball. You'll have that information already at hand. Something that I like to do is to test the corneal stability with a cotton bud or a Q-tip, just to see how stable that cornea is. And if I have any doubts, then I would not apply, a power tool to that cornea, because we can do quite a lot of damage. So the technique for debridement, if we have documented a proper sked or a non-healing superficial ulcer, we want to flush that eye with some dilute betadine, apply local anesthesia. And I do this multiple times throughout, so prior to, throughout, and after the procedure. Circular or side-to-side motion, or you can do a combination, the bed and the edges of that ulcer. And that's important because the bed is where that hyaline membrane may have formed. And so we want to clear all that away. And obviously the edges until we get to that nice stable epithelium. And I always caution our clients that the lesion will get much, much bigger, and it's often far more extensive than we initially thought based on fluorescein evaluation. We want to indent the cornea slightly and aim for about a minute depending on the size of your lesion. After I do my first debridement, I like to just take a pause, evaluate the margin of that wound with the slit lamp or head loops if you have them, just to see if there's any sort of ugly spots that I might want to go back to focally and tidy up. And I am a fan of the contact lens, but this is not obligatory. And so if you don't have them, if you're not comfortable using them, not to worry, you really don't need to. Grid keratotomy I've put on here with a question mark, because I think that procedure potentially has fallen a little bit out of favor, and I think that's largely because it's very difficult to do it in a controlled, accurate manner. So you've got that needle and you're making your grid. It's very easy to go a bit deeper than you intended, whereas with the alga brush, you have that safer approach. You're not going to be removing stable stroma. You really are just removing that hypertrophic epithelium. And so treatment and follow-up post-debridement, certainly first-line antibiotic prophylactic and a lubricant. These eyes are painful after a diamond burr debridement, so analgesia absolutely, and an e-collar. I like to recheck in 10 to 14 days, unless you are a Boston, a pug, or a Frenchie. I consider them to be lovely dogs, but they are corneal healing underachievers. And so I'd like to see them back in a week, just in case they've decided to go in a negative direction, so we can intervene more rapidly. Short-term complications that we can see, so certainly failure to heal. We might have to do a second or even a third diamond burr debridement. If you're not having the desired result, again, just going back and making sure that you really have ruled out that primary ocular problem. And occasionally we just have patients that they fail the DBD and they just need a superficial lamellar keratectomy, which is absolutely fine. Sequestrum formation we can see in our cats. These typically require a surgical approach. I have not personally had really any that have resolved completely with only topical therapy, despite having just a light T staining. And so often we're having to do an SLK in these patients as well. And then certainly what we all are worried about is development of melting ulcer. And so again, in these patients, of course, cytology, culture, intensive anti-melting antibiotic therapy, surgical stabilization, Paxi-XL if possible. And this is often they're not mutually exclusive. So often we have to employ one or all three of these in a single patient. So here's some examples of those complications that we don't want to see. Keratomalacia, the lower image on the left-hand side is an eye that was very close to perforation, and then early sequestrum formation in our feline patient on the right. Some of the longer-term complications we can see, so granulation tissue post-DBD, again, going back to that image that we saw on when we're not debriding, those eyes need typically a short course of topical steroids and some immunomodulation, so a tacrolimus or cyclosporin and a lubricant. Pigment and fibrosis we can also see particularly in our brachycephalic patients. And if you're seeing a significant fibrosis, regardless in these guys, I like to check them 4 to 6 weeks post-debridement just to make sure we don't have that insidious kind of creep of pigment coming in. And then just a reminder that if we have, if we have a fluorescein negative eye, we don't need to continue with topical antibiotics in those patients. So here are some examples of those longer-term complications. We have the granulation tissue on the left, pigment here in the center, pretty significant, unfortunately, in the patient on the lower image there. Obviously, that's going to have a negative visual impact for that patient. And here's some examples of fibrosis, and again, the lower image, fairly dramatic, unfortunately, post-debridement. With regards to prognosis, so there are many articles that have been published in the last 10 years or so, and the quoted success rate of DBD or similar procedure is about 75 to almost 100% after one treatment, and the complication rates quoted 5 to 20%. I take these numbers with a big grain of salt because no single study is comparable to another, and so some individuals looking at fibrosis and pigmentation as a complication, other studies targeting only keratomalacia or recurrence. And so ultimately, we can see that the procedure itself is quite successful, but I never say 100% to any of our clients, certainly. Across the board, I would say the studies show that brachycephalics are at an increased risk for complications, whether that be recurrence, whether that be infection. And so again, just looking at those patients in a timely manner to make sure they're not going in a negative direction. And then there are a few studies that suggest that the use of contact lenses might result in a decrease in healing time. So if you haven't tried them and you're interested, certainly a Bausch & Lomb or a human contact lens, absolutely, you could give it a go. And so some key points, if you have a chronic ulcer, absolutely ruling out that primary ocular disease. If you have doubts, just test that cornea with a cotton bud or a Q-tip to see how stable it is. Organizing those timely rechecks, just so you're not missing, if a patient is wanting to go in a direction that you're hoping they're not going to go into. And then absolutely letting your clients know it is a very successful therapy, but we can have some complications so that they're not surprised or disappointed. And so I put this picture up here because I find it to be quite dramatic. It's not post-sked. This is a puppy that came after a cat claw injury, so a perforating laceration. You can see the sutures in the dorsal area there. And for me, I felt this was going to be very straightforward. I was very happy with the closure, and then a couple of days after surgery, the clients let me know that the eye looked like it was bulging. And they came back in, and I did have an internal scream because I did not expect this. And so this dog ultimately did great. We placed a third eyelid flap. The eye was beautiful at the end of it all, but sometimes despite your best efforts and doing sort of everything correctly, sometimes things don't go the way that you would like them to. And so we are here. If you need advice, if you'd like to refer a patient, just let us know. We're very happy to see them.